Good afternoon. Welcome to our Facebook Live program on mesothelioma. I am your host, Rachel Sachs, Senior Director of Education at the Cancer Support Community. The cancer support community believes that no one can or should face cancer alone. So we work to help people cope with cancer and become more empowered in their treatment. Our team offers a range of services, such as patient navigation, financial counseling, genetic counseling, pediatric support, and more. People have access to free in-person services at 175 locations around the world. We also offer support online and through our toll-free helpline. I would like to welcome today's guest to the program, Dr. Kotecha. Good afternoon. Dr. Kotecha is a board-certified radiation oncologist and chief of radiosurgery in the Department of Radiation Oncology and director of the Central Nervous System Metastasis Program at Miami Cancer Institute. He is an associate professor in the Department of Radiation Oncology and Translational Medicine at the FIU Herbert Wertheim College of Medicine and an adjunct faculty in the Department of Radiation Oncology at Memorial Sloan Kettering Cancer Center. He has specialized training and experience in utilizing the latest techniques in radiation therapy for both cancer and non-cancerous conditions. His research background and clinical interests have primarily focused on the treatment of patients with stereotactic radiotherapy, including CyberKnife and gamma knife radiosurgery. He also specializes in advanced radiation therapy treatment techniques, including reirradiation, proton beam radiotherapy, and MR-guided radiation therapy. During medical school, Dr. Kotecha was inducted into the Alpha Omega Alpha Honor Medical Society, an organization that recognizes excellence in scholarship and in the profession of medicine. He has been an invited speaker at numerous national and international symposiums and has published multiple book chapters in over 100 manuscripts and peer-reviewed journals. His research bandwidth spans investigator-initiated studies to multi-center trials to National Cooperative Group clinical protocols. In honor of Mesothelioma Awareness Day, which was yesterday, Dr. Kotecha is here to help us learn more about this cancer. Before we get started, I would also like to recognize our sponsor, Novocure, for supporting us to have this very critical and important conversation. Thank you for joining us today, Dr. Kotecha. Let's get started.
Well, thank you so much for having me here today.
Wonderful. I have some questions for you first, and then we'll take some questions from our live audience afterwards, if that sounds reasonable.
Absolutely. And I think for anybody in the audience, please feel free to chat any additional questions, and we'll be happy to take them at the end of the talk today.
Perfect. To start, can you explain to us what mesothelioma is exactly, and are there any subtypes we should know about? And if you can talk about them as well.
Sure. So just for some background, mesothelioma is a rare type of cancer that arises from the lining of certain organs. An analogy that I commonly use with patients is if they think of the organs in their body, such as the heart or their lung, as an orange, as a nice Florida orange, specifically because I'm here based in Miami, Florida. But you have the orange itself, and then you have the peel of the orange. Mesothelioma is a cancer that arises from the peel of that organ. And the most commonly affected organs include the lungs, the abdominal cavity, and the heart. Now, in general, when people think about mesothelioma, they think about malignant pleural mesothelioma or mesothelioma of the lung. And that's because it's the most commonly seen subtype of mesothelioma in medical practice, which accounts for about 80% of our cases. When we're thinking about the subtypes of malignant mesothelioma, there are 3 broad histologic subtypes and then some very rare histologic categories. For the broad histologic subtypes, they are epithelioid and then sarcomatoid. And then there's one which is essentially a mix of those two, which is actually called mixed or biphasic. It has both of those components. Now, that biphasic or mixed component does have features of both epithelioid and sarcomatoid. Typically, patients need multiple tissue sections or even larger samples to demonstrate both of those components. The epithelioid component is the most common variant by far. It accounts for about 60% of the mesotheliomas that are diagnosed. So hopefully that provides a little bit of background about our topic here today.
It sure does. And thanks for breaking that down for us. Can you tell us who is at most risk of developing mesothelioma?
So asbestos exposure is the most important risk factor associated with the development of mesothelioma. And that's not just in the United States, but around the world itself. About 70% of cases diagnosed with mesothelioma in clinical practice, specifically of the lung, are connected directly to a past exposure of asbestos. Now, asbestos is a commercial name for a group of chemical minerals, and it's used in a variety of industries. The most common are, for example, it's used in cement, ceiling and pool tiling, automobile brake linings, and even in the shipbuilding industry. So any patients that we have, we ask them about that historical connection to any of those industries because they may not have known about specific use of those chemical products themselves. But when you ask them about their history, it could date back to that. I recently saw a patient, for example, who was a teacher who, when she went back into her history, she then realized that the school that she had worked in was actually undergoing ceiling maintenance at that time, now historically 30, 40 years ago, which kind of explained that reason why she, as an otherwise healthy individual, she developed asbestos. Now, in addition to exposure from occupational sources that we think about as the most common relationship, people can also be exposed to asbestos, although it's a lot less common, through natural sources. And we think that basically accounts for the remainder of cases that we cannot connect a direct exposure to.
Interesting. So, really, when you're meeting with patients, they really have to dig deep, go back to their history often, and figure out with you and your colleagues what potentially they could have been exposed to in various situations.
That's absolutely correct. It's very different than the typical patient we see in a clinic that sees thoracic malignancies in the chest, because most often these are lung cancer. And so, for example, small cell lung cancer, we essentially universally see that in smokers. Non-small cell lung cancer can be seen in smokers, but also non-smokers, especially as there are some genetic variants of lung cancer, people who have specific molecular alterations. It's very different than in mesothelioma. They're not anything current or genetic that we're thinking about. There's some likely historical exposure. And this is, again, not something that is current, not something that is in your immediate past. It's usually something more in your remote past when we're thinking 20, 30, or 40 years ago.
Okay, that makes sense. What are some of the main signs or symptoms of mesothelioma a person should look out for?
Well, I think it's important to, again, make clear what we were discussing, how that exposure to asbestos is not associated with immediate development of mesothelioma. So even if somebody comes into direct contact with asbestos, we don't expect them to have signs or symptoms of mesothelioma directly, although they can have other lung irritation and other symptomatology associated with that. Now, the most common type of mesothelioma, going back to the lung cancer, the lung-related ones that we diagnose in clinic, the initial symptoms are actually fairly non-specific. Patients can have chest pain, difficulty breathing, cough, hoarseness, night sweats, or potentially even difficulty swallowing. Now, some patients may have more diffuse or systemic symptoms, such as fatigue or weight loss, but these are most often found in patients who have more advanced disease. Now, as you can imagine, these same symptoms can also be associated with a wide variety of other conditions, including non-cancerous etiologies. For example, for the last 2 years during the COVID-19 pandemic, a number of our patients actually came to light because of these symptoms, may or may not even have a COVID test positive because of something else, but then their further workup and scans showed plaques, and they were actually ultimately diagnosed with mesothelioma. Those symptoms, when they are cancer related, are typically present for months or even a longer period of time. And that's even before they even come to medical attention. So it's not that a physician is typically working this up, but it's different than, for example, some more of the acute illnesses that we see. That being said, you can have a patient who has kind of chronic issues and then has a more recent acute exacerbation, and that brings them to medical attention or light. And then we go back and actually make this diagnosis. And then when you talk to the patient, their family, they do realize that maybe they had symptoms for a longer period of time.
Gotcha. So that makes sense. And I think with anything, we here at Cancer Support Community, and I'm sure you and your colleagues would concur that when you have symptoms such as you described, it could be mesothelioma, it could be a variety of things. So to not self-diagnose and to make sure that you get to see your, perhaps your PCP, and then they will refer you to a specialist should it be needed.
That's completely correct. And, when we think about this patient population, even with their history of exposure, for example, to asbestos in the past, and if they have new and chronic symptoms such as this, it could be other things like a chronic respiratory disease associated with prior asbestos use, which can be chronic, can be debilitating, can be worsening with time, things that we think about for cancer, but could also be cancers that are unrelated to mesothelioma, for example, non-small cell lung cancer or small cell lung cancer in patients who have, for example, smoking history as well.
Okay, thank you. Can you tell us a little bit about how it's diagnosed and if there are any key tests or scans a person will have to undergo and about each one of those?
Sure. So whenever we see a patient in the clinic for a new diagnosis, now whether this is mesothelioma or any other thoracic malignancy, typically a physician starts by taking a history from the patient to get an idea of those symptoms, review how long that they have been present for, how they have changed over time. Part of that is also to do a physical examination in the clinic. Now, for mesothelioma specifically, I think a couple of the physical examination maneuvers that could be done could be that a physician could tap on the chest to determine if there is fluid in the lung. They would also probably listen to your lungs to hear how you are breathing and to see if certain parts of the lung are opening or if there is an obstruction that is preventing parts of the lung from moving air in and out. Other things could include palpating the chest wall. We've seen patients in clinic who have disease that extends through the chest wall, through the ribs, and there could be a palpable tumor nodule that could be visualized or even felt. And so those are all items on the physical examination that are key to note. Now, there are a number of tests that may be used the initial workup for mesothelioma, and these really differ depending on how the patient comes to medical attention. Sometimes the patient starts with a chest X-ray, which is a basic radiograph, just imaging of the chest to look for any acute abnormalities, but potentially there could be plaques or other imaging findings that are more consistent with mesothelioma, but maybe they went in and they were suspecting a pneumonia. Sometimes patients advance to CT scans of the chest if there are non-specific findings or there are no findings on a chest X-ray alone, but the patient does warrant additional workup. When we think about cancer imaging, that is typically a PET CT scan, which identifies or provides us with metabolic information, something that's specific to cancer diagnoses. Now, to confirm a diagnosis of mesothelioma, typically one would need to potentially drain some fluid from the lung that would show cancer cells in that fluid, or potentially do a biopsy, which is a procedure that is used to obtain tissue from the lining of the lung itself. Again, go back to that orange and the orange peel analogy. We need to take a piece of that orange peel to really diagnose what's going on. Now, in certain circumstances, if it's not easy to obtain a diagnosis with these procedures, sometimes surgical intervention, typically a video-assisted biopsy in the operating room, or potentially just an open surgery and a biopsy may be pursued. Now, we always, in general, try to use the easiest and least invasive technique before proceeding to a more open intervention in patients. But for this disease, it's not always easy to make a diagnosis. To give you some idea, for example, there was a recent study that was performed on almost 200 patients with newly diagnosed mesothelioma that looked at how do we do with each of the diagnostic steps in working up a patient for that diagnosis. Examining the fluid from the lung only yielded a diagnosis in about a quarter of patients. A biopsy helped to determine the diagnosis in another 40% of patients. but as a minimally invasive approach, but an open surgical biopsy essentially provided a diagnosis in all patients. So again, we start with the more minimally invasive or the least invasive procedures, but then we need to move up until we obtain enough tissue. Especially now in the era of molecular-based medicine and practice for all cancers, tissue is really key to providing a molecular diagnosis of a cancer, to looking at specific features, for example, availability of targets for which we have potentially molecular targeted therapies, or we have specific markers that would tell us a response to, for example, immunotherapies as well. So we do need to obtain enough tissue, not just diagnose a cancer nowadays, but to have enough for molecular testing.
Okay, so you touched upon a lot of different items in terms of how one would diagnose and the process really from the least invasive to the most invasive, but that sometimes you have to go to that nth degree to get a firm diagnosis. So I'm assuming that there's a lot of key players that a patient and their loved one will interface with through the process. Can you tell us a little bit about who those players are?
Absolutely. So when somebody is diagnosed with mesothelioma, it's important to build a care team around that particular cancer patient. So this can differ at each facility. However, at our facility, so at Miami Cancer Institute, where I practice at, each patient is assigned a nurse navigator. And then we have a medical oncologist, a radiation oncologist, a pulmonologist, and a thoracic surgeon. Now, these healthcare professionals interact throughout the patient's care to really ensure optimization of the patient's medical status, for treatment of their cancer, and also alleviation of any cancer-related symptoms that the patient may be having. Sometimes we also involve additional providers, such as our cancer rehabilitation medicine team. A patient who's going for an extensive surgery potentially needs rehab before and after that procedure. We involve the palliative medicine team who will help with symptoms associated with the disease, or even symptoms associated with the treatments that we have to put the patient through, or even nutritional consultations. It does take a team of providers to truly care for each cancer patient. And although we work together to ensure we are all quarterbacks with our patients, typically at our center, the medical oncologist is truly the quote unquote quarterback for the team and will lead the patient through that diagnosis and will involve the other team members for the initial management strategy.
So, Dr. Kotecha, I think you would probably say and confirm that you described a bunch of different players in the team with, the oncologist being the quarterback. But we want to encourage patients to make sure that they get a diagnosis and treatment. So should they be concerned about finances or barriers in terms of psychosocial issues, I'm assuming that the social worker or financial navigator would also play a role in the team.
Absolutely. And especially as we think about multiple different treatments across different centers, potentially, this is something that our financial counselors and the social work team do really involve and engage with the patient from the very beginning. We recently actually had the patient see another facility for potentially clinical trial availability. And so our social workers were key into helping that patient transition from clinical care, for example, to our facility, to a different facility. And so we can encourage that relationship between the centers, but also so that we can make sure that the patient is financially taken care of from their insurance standpoint.
Perfect. So that's a nice segue into my next question about getting a second opinion. And as you know, that sometimes patients, feel that they go to their doctor and they trust their doctor, and sometimes they say, you're fine, or we're going to work you up, but we didn't find anything. And then the patient trusts that and is fearful either financially or not, having a relationship with their doctor already about getting that second opinion. But it's so important and key to get that opinion, to get to the bottom of things. Can you talk a little bit about that and what you encourage your patients to do?
Sure. So since mesothelioma is a rare cancer, the first thing is to always make sure that the pathology is carefully reviewed to ensure that the right diagnosis is made. Now, whether this is done in a community hospital or even an academic center, that needs to be confirmed first of all. As I'd mentioned, there's, for example, the biphasic part of mesothelioma or the subtype of mesothelioma, and that potentially requires additional tissue to ensure or to exclude whether the both components of mesothelioma are in the same pathology specimen. Now, After this is confirmed, then a treatment paradigm needs to be designed by a team who is experienced in treating that particular pathology, whether it's mesothelioma, lung cancer, or any other malignancy. Now, we commonly work with physicians in community centers around us in Miami, as well as other academic centers in the region and even around the country to help take care of patients who have these rare or even complex diseases. Now, having an open communication amongst the medical providers and really honest discussion with the patients is what allows us to provide good quality care for our patients, is ultimately each of our goals and should be a shared goal with the patient. So in essence, if somebody is diagnosed with mesothelioma, I would ask them to seek care at a facility who is experienced at treating mesothelioma and have a frank discussion with the doctors to see if there is a particular chemotherapy agent or radiation therapy or a surgical procedure that can be delivered at facilities that are away from home versus what needs to be delivered at a facility closer to home. Now, sometimes this requires a specialty therapy. An example that we have is proton therapy. I have a mesothelioma patient actually under beam right now, under treatment with proton therapy, that is driving from across the state because we are the closest proton therapy facility. They went and had surgery at a different facility and coming to radiation at our facility. So we can kind of coordinate. Now, sometimes a patient can require chemotherapy, which can be delivered at a facility closer to their home. And then they can have closer follow-up at the academic center every couple of months, but they can receive a majority of treatment at their home. So I would never be fearful about getting a second opinion. And I think that the era of maybe hurting a physician's feelings by getting a second opinion is kind of past. You know, we are in the information age. Everybody is their own doctor by going on Google as it is. And so I always encourage patients that if they have any questions, if they want to know about any other treatments, to potentially get a second opinion. And I have no problem with that. The one comment that I always have about second opinions, though, if patients ask, is that at least talk to your physician about it openly and honestly, and then maybe get a list of physicians that would be good places or good people to get a second opinion. So sometimes what I would do is if a patient asks for a second opinion from our standpoint, then I would give them a list of maybe 3 or 5 people that I think would be good people for that patient to see in different parts of the country. Somebody in New York, somebody in Texas, maybe somebody in California, and then that patient can choose who they would like to see. So I'm not giving them just one person, but then if they go out and seek out an opinion with somebody else, they may not actually see the person who's the specialist for that. So I try and help to facilitate it for other patients, because we see a significant proportion of our patients as second opinions or third opinions at our facility.
Perfect. And we here at Cancer Support Community certainly encourage our patients and caregivers and empower them that they are their own best advocate, and to make sure that you do your homework, and that physicians are used to patients saying, I want to get a second or third opinion. And then often the patient will come back closer to home if, like you said, that level of service can be provided close to them. Wonderful. So you really segued right beautifully into this next question. If you could tell us a little bit about the main treatment options and the benefits of each of those.
Well, there are a lot of treatment options for mesothelioma, which is a good thing that there are many treatment options that are available, and we really try and personalize it to every patient. So I'll go through the kind of major categories of treatments that we use for this patient population. I think one of the biggest decisions to make is whether the patient's going to have surgery as part of their treatment course. This decision is not easy and is typically made by a multidisciplinary team that is comprised of the specialists that I mentioned before from all of the multiple disciplines that treat mesothelioma. At our facility in Miami, all of these patients are presented at the Thoracic Multidisciplinary Tumor Conference so that we can make a decision with regards to the surgical need or the other treatments. Now, all patients will receive some form of systemic therapy, but about 1 in 5 patients, or 20% of them, will also be candidates for surgery as part of a combined modality treatment approach. Now, the true role of surgery and its benefit in this patient population is still being evaluated as we learn more about the biology of this disease, because we're learning more about which groups of patients actually require surgical intervention. But overall, for the patients who go to surgery, the goal is to resect as much of the tumor as possible, regardless of the surgical approach that is taken. Now, the surgical team really has to take into consideration a number of factors with regards to the patient's ultimate selection for surgery. And these are the things that we discuss extensively at our multidisciplinary tumor conference: the histology of the mesothelioma, the patient's performance status, the age of the patient, their medical comorbidities, their blood counts, the extent of disease, their tumor volume, their heart function, their lung function, amongst other factors. There's a lot of things that go into that decision because that's ultimately the most important decision from your initial diagnosis. Now, there are a number of different surgeries that can be used in patients with mesothelioma. The most common surgery that is known of for this tumor or this disease is an EPP, or an extrapleural pneumonectomy. Now, it's when the lining of the lungs, think of the peel of the orange, is resected, but also with the lung itself. The lining of the heart and the diaphragm, which is the muscle that separates our chest from our abdomen, all of those are actually removed. Now, in some cases, if the heart lining or the diaphragm muscle is not involved, these may be potentially left in the patient. There's a different type of surgery which the lining of the lung and all the tumor is removed, but the rest of the tissues and organs, such as the lung itself, are actually left intact. That's a less extensive surgery, but it's actually gaining more prominence. There's also in-between surgery in which, sometimes you can do kind of part of one surgery and a part of another surgery. And then the least invasive surgery is actually just to do an open biopsy or a partial resection to get enough tissue to make the diagnosis, but you're really not doing a curative surgery to some degree. More extensive the surgery, the higher risk of complications and mortality. And so patient selection is really key to determining which patients should go to surgery. So that's the first bucket of treatments.
Okay.
The second bucket I think of as systemic therapy. So those are therapies that are going to go throughout the body. Essentially, for mesothelioma, those are categorized into two treatment approaches. One is chemotherapy, and the second is immunotherapy. Chemotherapy is integrated into the management of patients who receive surgery and or even radiation therapy. And for patients who have unresectable disease, cannot have surgery to remove it, in the rest of the world, a 2-agent chemotherapy regimen is commonly utilized. In specific countries like the United States, a 3 chemotherapy agent or 2 chemotherapies and a biologic agent are actually used at the same time because there are some studies that show that that improves the survival of patients. Now, there are a number of new clinical trials that are investigating different chemotherapy agents. And then more recently, the combination of chemotherapy and immunotherapy is being tested as well. So immunotherapy has really led to significant advances in the management of patients with lung cancer and other malignancies. And there have been some really exciting trials in the mesothelioma space that have demonstrated promising activity with immunotherapy and mesothelioma. We had a very large multi-center study in which about 300 patients participated in, and they were randomized, or there was a coin that was flipped. Half of them received the standard chemotherapy, or half of them received 2 different immunotherapy agents at the same time. In this trial, the patients who received the immunotherapy overall lived longer, so about 18.1 months versus the historical for this disease, which is about 14.1 months. And so we are excited that that got an accelerated approval and then became part of our clinical practice very quickly. The last group of treatments, I think, are local regional treatments that are non-surgical. And there's, again, I would divide into 2 buckets. The first is radiation therapy. That's essentially what I do on a daily basis and is often utilized in patients with mesothelioma, either in conjunction with surgery or even as a palliative treatment to alleviate symptoms or sites of disease in patients who are not going to go to surgery. Now, the choice of the surgical intervention and the overall stage of the patient, their performance status, and their extent of disease really helps us to decide when radiation therapy is needed, how much radiation therapy is utilized. Commonly, if patients are not going to surgery, but they have symptoms, for example, for chest wall disease or involvement, we can treat them with anywhere from 5 to 10 treatments of radiation. So it's about 1 to 2 weeks of radiation. In patients who go to surgery, radiation therapy does improve the control rate of cancer over surgery alone. That's typically with more extensive surgery, and that's typically given over 5 or 6 weeks. The last bucket of treatments that are local regional, similar to radiation therapy, are tumor treating fields therapy. Now, our cancer center was actually one of the first in the country to institute a program to treat patients who had unresectable disease with tumor treating fields. Now, these are different than radiation therapy. They are delivered via a portable, non-invasive device that provides a local regional treatment to the area of the chest. And there are transducer arrays, which are sterile. They're placed on the chest by the patient or their family member. And that placement is designed based on their CT scans, the extent of their disease. And those deliver alternating electric energy throughout the lung spaces to be able to control the growth of the disease. We know that the frequency to set those tumor treating fields to, based on studies that show the sensitivity, as well as how they work in combination with chemotherapy. So essentially, that's the umbrella for all of the basic treatment options for this patient population.
It seems extraordinarily extensive, and that you really have to meet with your care team and figure out, again, what your comorbidities are, age, et cetera, your functioning status, your particular issues that you're having, and then you develop the plan. And I would imagine that sometimes based on how the patient's doing, that plan can shift and maneuver.
Absolutely. So, for example, if a patient is starting their systemic therapy and they're starting immunotherapy for their lung cancer, for their mesothelioma, and then they have disease progression, well, then they're going to potentially switch to chemotherapy. Potentially, they are going to have radiation therapy to palliate areas of disease progression. So, a patient kind of shifts between all of those treatments. And actually, in general, most of our mesothelioma patients receive most of those treatments, not just one of those treatments uniquely.
Okay. So, Dr. Kotecha, can you tell our audience a little bit about clinical trials and the importance and how it could be relevant with mesothelioma?
Sure. So our facility at Miami Cancer Institute is very focused on clinical trials. And we are specifically focused on offering new treatments to patients, especially in our region, but we do see patients from around the country for unique diagnoses or for novel combinations of agents, for example, with radiation and systemic therapy, or new systemic therapies that are coming onto the market. Now, mesothelioma is a rare disease in the United States. For example, I think last year's estimate was just over 3,000 cases diagnosed. So for patients with newly diagnosed cancer, or even a cancer that has progressed on prior therapies, we always try to determine if a clinical trial is available to them to give them the ability to have increased access to care for additional options. That also, I think, advances our understanding of the disease. And my personal bias is that it advances the science of medicine. So I think for all of those reasons, whenever we're discussing treatment options with a patient, we always encourage them to explore if clinical trials are available to them based on their disease and stage. In fact, for our thoracic malignancies clinic, our modus operandi to some degree is to always offer a patient a clinical trial option first, and then standard of care options as a second best approach. Now, not every facility can have every single clinical trial. And so we often work with other facilities to ensure that patients have options that are available to them, even if they're not specifically at our facility. On the other hand, we also see patients from all over the country for clinical trial options that are unique to our cancer center. We have treated a number of patients throughout the state and actually even out of the state, for example, with tumor treating fields therapy, given that we were one of the first institutions to be able to offer that in the United States. Now, I also tell patients and emphasize to them during their entire disease course that being on a clinical trial also allows them to have access to a research team. We have clinical research coordinators and a clinical trials research nurse, and those are good advocates for the patient. The patients typically were on clinical trials require more frequent monitoring than our standard of care treatments, even if they are, for example, on a trial in which they're randomized to standard of care therapy alone. And so in my mind, I think this is an added benefit to the patient, especially given what we've gone through with the last couple of years in medical practice and transition and facilities and issues. I think having more people keep eyes on the patient is only to the patient's benefit. I also feel that patients actually develop a very strong bond with our clinical trials team. In fact, for example, whenever they progress on a clinical trial or research study, I know the research coordinators are always trying to search, well, could there be another clinical trial that the patient could go on to, because they develop such a close bond with them that they do want to offer something new to that patient, and they are frequently a resource. In fact, we're almost having to make sure that patient questions actually come to the clinical team if they're unrelated to the trial, because they develop such a close bond with the research coordinator and the trial nurse that they start to ask them everything, even unrelated to their cancer diagnosis. But I think that's just a testament to how clinical trials can improve a patient's care.
Absolutely. And the relationship and the importance that the patient has to the care team and vice versa. Can you let us know if mesothelioma can be cured and what the goals of treatment are?
So based on the stage of the patient, the goals of treatment could be to cure the cancer, or they are to alleviate symptoms. Now, in most cases, if we're curing the cancer, we're also going to alleviate symptoms at the same time. And this is important really in cancer and medicine to establish with the patient at their upfront diagnosis. I think it's being increasingly recognized in the cancer community that as oncologists, may not communicate that. And even if we're communicating it, it may not be something that's understood by the patient. Patients don't often understand if they're actually being cured or if the treatment is in a palliative intent or nature. Now, specifically for malignant pleural mesothelioma, this unfortunately does have a poor prognosis overall, and the median survival for most patients is actually anywhere from 6 to 18 months if you look at population-based estimates. Now, there are a number of newer therapies and interventions in this space, as I mentioned, with ongoing clinical trials combining chemotherapy and immunotherapy. And for example, some specific subtypes of mesothelioma, like the epithelioid subtype, treated with tumor treating fields therapy and chemotherapy, or some subtypes treated with immunotherapies. Potentially, we're seeing survivals that are much longer than this kind of range. But I think it's important to note what is seen on a clinical trial, which is one aspect, what is seen in clinical practice for what patients receive as their best care and other research studies, retrospective research studies at academic centers. And then finally, what do we see in the overall patient population? Because the population-based estimates show us that people who may not actually come to specialist medical attention, they may not get actually the full treatment care that could be afforded to them because of other social circumstances. And so I think it's important to keep light or keep aware about kind of those categories of how we estimate a survival for a patient. Now, if in general, if patients have localized disease, they're candidates to receive aggressive multimodal therapy, which is chemotherapy, radiation, and surgery. Then a patient who makes it through all of those treatments potentially has a longer estimated survival and potentially can be cured. But it's a difficult disease to treat. For patients who have incurable disease, even sometimes a palliative surgery can help improve their breathing. Radiation therapy in short courses, as I mentioned, can alleviate symptoms from painful chest wall disease. Chemotherapy can help overall slow the burden and growth of disease, even if it's not going to cure them.
Okay. So, on that light, what are some ways a person can improve their quality of life during and after treatment? Some, as you know, some diseases are very debilitating, but we know that daily exercise, socialization, even coming out of a post-COVID, if that's what we're in right now, it's hard to determine day-to-day world, are so key and so important. And having that spirit and being level emotionally is probably key with so many diagnoses, especially mesothelioma.
Absolutely. I think, this is an under-recognized area of a cancer patient's care and of their journey. A couple of things that I strongly recommend when we see a patient, especially if they have significant symptoms related to their disease, related to their cancer, are number one, to meet with our palliative medicine team, our cancer support services team. They are excellent, and really we'll do a full survey with the patient to see what symptoms are they having, even things like uncontrolled nausea. To me, nausea is kind of the worst feeling in the world. I'd rather be in pain than nauseated. But those types of symptoms, I think, are very well managed by our palliative medicine team. So that's number one, is we always kind of set them up with that service line. Number two, and this is one of the benefits of our facility, is that we kind of have a robust physical medicine and rehabilitation team. And so they will do basic tests for the patient. If a patient is able to kind of sit to stand in a certain period of time, if they're able to do certain activities, well, that does affect their quality of life, whether it's from their cancer, from the treatments, or their overall medical status and comorbidities. So we get them in with their cancer rehab team, and so they can actually talk to them and prescribe either physical therapy or occupational therapy or any other treatments that the patient may need. And the third is nutritional status. I think, as patients get through their cancer treatment, we have certain nutritional, I'd say, requirements that we would like patients to get through. I advocate for 2,000 calories a day. And especially as you see patients go through things like chemotherapy and radiation therapy, if they're not getting that adequate caloric intake, then you see them lose weight, they decline their performance status, then you start to notice they miss cycles of chemotherapy. They don't make it to all their radiation treatments. So those are the kind of the first three things that we do: palliative medicine, cancer rehabilitation, and nutritional services. Outside of that, we also engage with the patient and their family about their disease course and really educate them about what their treatment is going to be, their appointments, how long they're going to be, how are we going to interrupt somebody's life with this, and so that they can develop a caregiver team to help them through this journey. Sometimes that team could include members that are of their family or friends, but sometimes that team could include people they meet through other cancer support groups, such as the society, or even through asbestos.com or through other means, for example, at some of the cancer support groups that we have at our facility. So.
Okay, perfect. Another beautiful segue into our next question, which is, as you know, a caregiver for a loved one of any chronic illness is so key and so critical and critically important. What role do you feel, Dr. Kotecha, caregivers play during the mesothelioma experience?
Yeah, especially because mesothelioma, it is a cancer that not only causes symptoms from the cancer, but it destroys the organ that it is affecting as well. So you see some cancers that don't do this. Like an example is breast cancer. It can cause localized symptoms if you have a large breast mass or it goes through the skin. Those are localized symptoms related to the cancer, but there's no organ damage from the cancer itself to some degree. That's very different than in mesothelioma, and patients often have symptomatology related to this or are compromised from a lung standpoint, from just a general performance status and capability standpoint. So they really depend on their caregivers to get through this. I think it's a very rare occasion I can count on one hand or less how many times I've seen a mesothelioma patient show up in the clinic by themselves. They always have a caregiver with them, so we can discuss with them, what is this cancer journey going to be. I actually love to see caregivers come with their notepad if they have questions, if they're taking notes, then they're engaged in the patient's care as well. So they do play a really important role.
Perfect. We agree. And like you said, the caregiver should go to the physician, the care team, which is very, very extensive in cancer treatment, particularly with mesothelioma. Cancer support community, other support groups are out there to help support. So we're only a phone call away, and I know that the navigators are there to help. So we encourage our caregivers to definitely reach out. Can you tell us if there's anything, if you were thinking along the lines of the next 2, 5 to 10 years about treatment for a mesothelioma and what you're projecting and what your hopes are?
Sure. So I think we're understanding a little bit more about the biology of mesothelioma. So for example, in the large clinical trial that I had mentioned that led to the approval of immune checkpoint inhibitor therapy or immunotherapy for mesothelioma, we are learning that some subtypes respond very well and we made significant strides, and some subtypes did not respond as well. Now, whether we need to start combining some of our treatments, for example, adding tumor treating fields therapy to immune checkpoint inhibitor therapy, to treatments that in the preclinical models have shown to work together, maybe that will be the way forward. I think we will learn more about the biology for who should receive which therapy with regards to personalized treatments. And really an unearthed area is the use of targeted therapies. When I think about a parallel example with lung cancer, we know that there are certain molecular subsets of lung cancer, whether they're patients who have an EGFR mutation, an ALK rearrangement. These are all kind of letters that people think about. Those actually correspond to specific subtypes of lung cancer. And now we actually have targeted drugs that work against those lung cancer types. For example, for patients who have the ALK rearrangement in their lung cancer, our therapies have a response rate that is 60, 70, maybe even 80%. So we understand the biology and we can match a treatment to that biology. It's not just one diagnosis. And so in mesothelioma, we have identified certain targets for systemic therapies, but really have not seen significant strides or advancements in that space. And then finally, from a radiation standpoint, from my specialty, I think we are learning how we can use more advanced radiation treatments, and we can provide kind of local regional treatment that radiation provides in durable local control, because this is a locally aggressive disease. But we've been stuck with a lot of the side effects associated with the treatment, lung irritation or inflammation from radiation. And so now we're trying to figure out, could we advance our treatments? Could we introduce things like proton therapy that we've done in other diseases to be able to allow more precise radiation to just treat that lining, but spare the lung itself? Can you treat the peel of the orange, but save the orange itself? So that's going to require some more advanced radiation, but also we need to know which patients we should select for those types of treatments.
Okay, that orange analogy is great. So here's a question. I would encourage the audience and listeners to drop any questions at this time. Here's a question that came in, Dr. Kotecha, and I want to make sure you're comfortable answering it, or if we should refer the listener back to their healthcare team. So this is from Mary Ann. She states, I was cancer-free 20 years ago, but now as of May 2021, I was diagnosed with cancer stage 4 that spread to the lung. I'm on Verzenio and letrozole. Is this good medication for what I have? It's been really hard.
Well, Marian, I'm really sorry to hear that story, and especially with a 20-year interval from cancer. The first thing the medical team should actually evaluate is whether this is the same cancer that you had at that time, or this is what's called new primary. It could be even in the same organ, the same location. It started from the same place, but it potentially can have a different tumor biology than what you were initially diagnosed with. Now, just from the treatments that you are on listed, so Verzenio and letrozole, that's typically used for patients with metastatic breast cancer. So even if it spreads to the lung, different than, for example, our mesothelioma patients, because we do not typically use hormonal therapy such as letrozole in this patient population. So I'm unable to comment on this particular case, but definitely something you can discuss with your healthcare providers, or as we discussed actually earlier in the session, about seeking out clinical trials or even second opinions. I think that's always appropriate, whether you are newly diagnosed, whether this is your recurrent disease. Actually, just saw a patient in clinic earlier today. He's been through 5 different lines of therapy and is now looking for, at a different facility, is now looking for a clinical trial option at our facility. And I think having a second opinion is never wrong or never a bad thing. At the end of the day, if all it does is provide you with information and educates you about your disease, your cancer treatment, and if they agree with what your current treatment is at your facility, then it would only make you have more assurance in the treatment that you're getting. So again, I personally never see any harm in asking others for input or for second opinions, but I think that's a generational thing.
Thank you for your sensitivity in answering that question. So before we close today, and this has been a really enlightening and fascinating discussion, and we thank you so much. Is there anything else you want our listeners to know about mesothelioma?
You know, I would say that it is a chronic disease. Whether you are a patient who is going to go through extensive surgery, chemotherapy, radiation for the chance of cure, or whether you are a patient that's going to be receiving systemic therapy, tumor treating fields treatment, radiation therapy, even to palliate symptoms, it requires multimodal treatment. It requires an entire care group. And so getting all of those people to be part of your cancer team is really key. And looking at clinical trial options, potentially traveling to other facilities, all of that is really key to be able to see what is the newest, the most novel therapy that is available for you.
Beautifully said. Dr. Kotecha, thank you so much for joining us today. The information and insights you shared are without a doubt invaluable to our listeners and to us here at CSC. Thank you again to our wonderful sponsor, Novocure, for making this conversation happen. It's been my absolute pleasure to have you join us today for this wonderful conversation. If you have any questions about mesothelioma, making treatment decisions, or anything else that we've discussed today, or just generally about cancer, please contact us with our experienced and licensed navigator at our cancer support helpline. The number is 888-793-9355. Again, that's 888-793-9355. You can also visit our website at www.cancersupportcommunity.org. Thank you, Dr. Kotecha, and thank you all.
Thank you for having me.